part of management. So, come to my presentation. What is non-STEMI? If someone need a definition of non-STEMI, I would say is myocardial infarction without ST deviations. As there is myocardial infarction, so there is myocardial cell death or necrosis. So reflected by positive biomarkers, troponin, CK, MB or whatever. So that is simple definitions of non-ST elevated myocardial infarction. Before going to my presentation lecture proper, I would like to go through pathophysiology, which make easy for you to understand the mechanism, and also when you decide the management, I think it's most important. So what is the pathophysiology? When you are born, you born with very nice and clean coronary arteries. Most of us having three, that epicardial coronary arteries, and 95%. Now, if you look at the coronary circulation, so 5% epicardial, and 95% is penetrated. What's it called? Microvasculature. So as interventional cardiologists, we are dealing with 5%. But as cardiologists, we are dealing with 100%. So it's very important. And then we'll come to the pathophysiology. So we are born with very clean coronary arteries. With the time, you get atheroma formations. Atheroma is made of cholesterol and fibrin, elastic tissue, and is nicely covered by collagen tissue, what is called cap. And on top of the endothelium is intact. That is most important. Endothelium is intact. With the time, what happened? There is gradual increases in size, leading to narrowing of luminal area. When it reached to more than 90% obstruction in the luminal area, you started to feel in chest pain or exertion. That is classical angina, what we call stable angina, exertional central chest pain, deviated to several phases and relieved by rest. That is stable. And if you look at the anatomy, the pathophysiological processes within the plaque, they are very calm and quiet. No much inflammation. And endothelium over the plaque is very smooth. And if you look at the platelet activation, there is no much platelet activation. There is no coagulation activation at all. So you get only pain in exertion. And so as there is no myocardial infarction, there is no autonomic symptoms. So no nausea, vomiting, no sweating, especially in patient with stable angina. So that is very important. So there is no much inflammatory or proliferative changes or platelet or coagulation cascade is activated. For some reason, this plaque gets unstable. We don't know reasons. There are so many reasons. There are, we know most of the reasons, all these factors get unstable. It's like, volcanoes. All of a sudden, volcanoes can erupt. Until volcanoes erupted, it's very safe. You can enjoy on top of the volcanoes. Once it's erupted, so you get devastating effects. So what happened? So first thing is we'll talk about unstable angina. The coronary plaque, there's rapid swelling due to so many reasons. So there's rapid deterioration in whatever the luminal area. So this is associated with imbalanced demand and need. So patient develop chest pain even at rest. That is one definition of unstable angina. Or worsening angina. There is no time myocardium to adaptation. So they get worsening angina, what we call crescendo angina. So these are the definitions of unstable angina. And also if you look at the microvascular pathophysiology, there is no much platelet activation and even the endothelium is very intact. No endothelial erosions, no endothelial ulcerations, and so that there is no much platelet activation, no coagulation cascade is not activated. So there is no associated myocardial infarction, no myocardial death. So there is no much autonomic symptom. So they are coming in worsening chest pain or resting chest pain without much autonomic symptoms. When it progresses to non-STEMI, what happens is associated with endothelial erosions and ulcers without past plaque is being ruptured. So when endothelium is eroded, the the platelet get activated, attract more and more platelet, start forming platelet plug on top of unstable plaque. So leading to near total obstruction of the coronary flow, and these thrombi can dislodge to the distal circulation. And then they dislodge and block the distal circulation, especially the microcirculation, resulting in myocardial, patchy myocardial death and myocardial necrosis. So especially the most vulnerable site is subendocardial. So you get subendocardial infarction, what we call non-steroidal subendocardial myocardial infarction. That is the previous alter. As your patient having ongoing muscle necrosis, myocardial infarction, they are having prominent autonomic symptoms, nausea, vomiting, and palpitation, faintness, everything. So differentiation between by history unstable angina and non-STEMI is they are having resting chest pain with more autonomic symptoms. And then I'll just talk about STEMI. What happened in STEMI? For some reason, this plaque is ruptured and the coagulation, ruptured and this collagen cap is exposed to the blood. So it activates coagulation cascade. So once coagulation cascade is activated, it ends up with forming a pool clot which is rich in fibrin and red blood cells. So different between non-STEMI and STEMI, this is rich in fibrin and red blood cell, what we call red thrombi, but in non-STEMI is white thrombi, mainly platelet. And as the coagulation cascade is activated, so there is large clot is formed. So there is total obstruction over the ruptured plaque. Unless you open up or the nature open up, there is total blood cut. So beyond that, there is transmural ischemia followed by transmural necrosis. So that is, then you get ST elevation in the ECG. Why you don't get ST elevation in non-STEMI subendocardial? There is no transmural. In non-ST elevation, ECG may be normal because I said it's patchy, or maybe you get most pathognomic ECG changes will be ST depressions. So that is pathophysiology of acute coronary syndrome. Can I ask two questions? We talk about primary PCI in STEMI, but not in non-STEMI. We are talking about thrombolytic in STEMI, but in non-STEMI. Why? Can you answer? Can we give thrombolytic in STEMI? Why? So there are two reasons. One reason, if you look at the thrombus in STEMI, it's rich in fibrin and red cells. So what we are giving thrombolytic is fibrinolytic. It acts on fibrin. So that will help and will dictate the breakdown of the fibrin and lyse the heart. But if you do thrombolytic for non-STEMI patient, it's mainly rich in platelet. So there is no much fibrin. So there is no effect on the heart. That's one reason. This you get only complication out of fibrinolytic. There is no inside on-site effect. And also especially why we give this fibrinolytic to open up the artery. Maybe it's 1 or 2%. We won't expect 90% or 100% opening up of coronary artery. But in patient non-STEMI patient, most of patients are having intact circulation, distal circulation, because it's near total occlusion in most of the time. So now after understanding, knowing the pathophysiology, now you have to approach your patient. How to approach when you get a patient with non-STEMI? No, patients are not coming as I'm having just non-STEMI, they are coming with chest pain. So first thing is evaluation. You need urgent rule in and rule out. And once you rule in, so rule in means rule out the other causes, and you need very important, very early risk assessment. I will come to later, and then you have to go for guideline directed management. So how do you now rule in a rule? How really this is a patient by chest pain, and if you look at the number of patients coming with EQs, most of the time is non-cardiac. More than 90% of patients who come with chest pain are having non-cardiac. So only 10% having cardiac, of which maybe another 5% having acute coronary syndrome. Most others having chronic stable angina. But in acute coronary syndrome, time is muscle, muscle is life. So you have to act very promptly to prevent them, to save the muscle, so you are saving the life. So history is very, very important. So I am not going to read out all the things, but you can differentiate central angina chest pain. If it is rest or worsen, it is unstable, and associated with sedation and all these autonomic symptoms, it's more likely non-STEMI. So how do you differentiate STEMI and non-STEMI? STEMI having persisting chest pain because artery is totally blocked until you open up. Patients are usually having chest pain, and their autonomic symptoms are more pronounced because there is much myocardial necrosis and death. So that's very simple. Even with history, most of the time you can diagnose what you are dealing with, and also you have to rule out other non-cardiac causes. That is very important. And also, I am not going to read all the risk factors that you have to rule it out. And then you have to rule out the non-cardiac patients, and you have to rule in the patient with cardiac chest pain, and of which you have to keep in the ETU patient with acute coronary syndrome. And once you get acute coronary syndrome, very easy, do ECG. If the ECG is having ST elevation, yes, you have to follow the STEMI algorithm. If you are in the center where thrombolytics are available, if you are center where primary PCI available, just send to primary PCI, otherwise thrombolytics. Okay, and when there is no ST elevation in ECG, yes, it's a suggestion of non-STEMI. You need urgent ruling, so you do troponin. The cardiac marks, you can do troponin or whatever, but it's available one is troponin. You do high sensitive troponin. Why high sensitive? Is it different troponin? No, it's not a different troponin. It's a different technique of catching it up. So you do high sensitive, and also now I would say the previous guideline is 1 hour and 3 hours, but now it's 1 hour, 0 hour and 1 hour. Because if you do high sensitive troponin in 0 hour and 1 hour, 99 cases either you can roll in or you can roll out. So no need to do this on these 3 hours and 6 hours unless you really suspect. But majority of patient you can roll in with 1 hour, 0 hour and 1 hour. Right. And then now you have taken the history, you have ruled in the patient. Now don't panic. If it's STEMI, panic and just get your cardiologist and send them to the primary PCI in setup where primary PCI is available. But non-STEMI. Is it not always cardiologist so? Because we are dealing with only the 5% of epicardium in this situation. So 95% when you can manage. Right, non-STEMI. So what is the most important thing? Once you diagnose, you have to have risk stratification. Why this is important? This risk stratification predict in-house and 6-month mortality, cardiac mortality. If the mortality is higher, you need more invasive or early invasive management. But it's not like STEMI all patients should go to the ideally should go to the cath lab. But non-STEMI, no. High risk patient, if you select high risk patient, if you take the cath lab, the benefit will be very high. But if you take low risk patient, actually we are doing harm rather than doing good. So intermediate risk patient, gray area, depending on age and anatomy and all. So that decided by basically the cardiologist. So but your job is to stratify the risk. So there are so many risk scores, but what most of guidelines, especially BSc and BSc guidelines, recommend risk score. But you can use TB score also. So what if you look at TB score, there are seven scores, marks for each and every point. If it's very easy, if it's less than 2, it's low risk. And if 2 to 4, intermediate is more than 4, high risk. If high risk, patient should end up in a card, ideally in a cath lab within 24 hours. But intermediate risk, we don't have much data, you have time. But low risk, even they can manage it more. You don't need to rush to the cath lab. But this is TB scores are not very, very validated, so you go for the gross case score. Again, you can calculate almost all. You use smartphone, so you can calculate case score. Very simple. It's only take only 30 seconds. So if it is 100 or score is 100 or 140 is high risk. So then you need cardiologist help. So if it is 140, yes, cardiologist, because it predicts that the in-house mortality and morbidity is very high. But in between 109 to 140 is again gray zone. So it's still better if they can end up in cardiology unit and rather than 109, yes, even we can manage it more. This is very important. So this risk stratification is very important that it helps to decide the plan of management and also how urgently your patient should undergo coronary angiogram or not. That is very important. Right. Now, after all your risk stratifications and we have initial stabilizations of your patients. So as Dr. Ajit mentioned, I am not going to read because everything Dr. Ajit has covered. But oxygen, as he mentioned, oxygen when necessary when the oxygen saturation is less than 90. One reason is oxygen is vasoconstrictor. In high concentration, in associated vasoconstriction, especially the coronary constriction, and also there is associated periapical formation. So, an antiplatelet. This is important. Now we are dealing with non-STEMI. The antiplatelet are very active, so we have to block them. Try to block as much as possible. So that's why we are using dual antiplatelet. So use aspirin, as Dr. Ajit mentioned, is thromboxane A2 inhibitors. So it inhibits platelet by inhibiting thromboxane A2. So what loading with the loading dose, and this is important because most of the time we are using higher doses. So what is the dose? You can give initial 300 of loading dose, but maintenance is important. Fact that you are continuing, especially in non-STEMI patient, you are continuing dual antiplatelet. You don't need high doses. If you are using dual antiplatelet P2Y2 inhibitors in combination, even 37.5 milligram of aspirin totally block the totally block the thromboxane A2 receptors. So giving more high doses, you are getting only the bleeding risk. So it's pretty enough to continue 75 milligram because dual antiplatelets are recommended for 2 years. Sorry, 1 year after non-STEMI, irrespective of you have put a stent or not. But these are not very hard and fast rule. You can, it's very flexible. If the bleeding risk is high, you can take antiplatelet out. If there is no bleeding risk, you can continue. If you think that the ischemic events are higher, you can continue longer time. Right. Then P2Y2 inhibitors. P2Y2 inhibitors, you know that there are many molecules. I am not going to go on because Dr. Ajit Kolrat already explained, but just clopidogrel, ticagrelor, and prasugrel. The clopidogrel old version is irreversible inhibitor, prasugrel again, and then ticagrelor is reversible. But in non-STEMI, in acute coronary syndrome, all the guideline, because just something about guideline and recent data, so they prepare prasugrel. Why prasugrel is prepared? Prasugrel is associated with reduced stent thrombosis and stent thrombosis related myocardial infarction and also recurrent myocardial infarctions. So they prepare prasugrel. So now this is important. If you want to give prasugrel in ET7, don't give. What the guideline recommend, pre-angiogram, without doing before angiogram, without delineating coronary angiogram, it is not advisable to give them prasugrel. Reason is that according to the trial and data, it's not going to improve the outcome. Actually, it increases the bleeding risk, and also it sometimes delay the CABG, because all the patients who go into the cath lab for non-STEMI and not end up in STEMI, depending on coronary anatomy. Some patients may end up in bypass surgery. So if you load it with prasugrel, so it delay the bypass surgery and also just increase the bleeding risk. So if you want to give prasugrel, don't give prasugrel with the EDU setup. So we'll give in cath lab once we delineate the coronary arteries. But ticagrelor and clopidogrel, there's no issue. You can load and you can give even in the EDU setup. And pain relief, as you know, give morphine. That's okay. And then the long-term management I will come later. That already I have. And then how do you know? No. STEMI is always, all the patients should go to the cath lab or immediately open up if it is possible. But in non-STEMI it's not. Only certain percentage of people should go to the cath lab. High risk patient, usually case score is more than 140, anti-me score is more than 4. Should go to the cath lab within 24 hours and do the angiogram. Check whether the arteries are stentable. If stentable, stent in, but otherwise if stents are not possible and other sources are there, so if then you go for bypass surgery. It is depending on the coronary artery anatomy. And also there are certain percentage of patients they can come with life-threatening complications due to non-STEMI, such as cardiac shock, recurrent ongoing angina, may life-threatening arrhythmias, cardiac shock. So that you have to take them within 2 hours of hospital admissions. And then the low risk patient, when the case score is less than, especially the 109, anti-me score is less than 2, you don't need to take them to the cath lab. So you can discharge. Maybe you have to keep in 1 or 2 days in the hospital and you can discharge, and then you do what we call ischemia guided revascularization. So you put them on some sort of stress test. Maybe exercise EEG, maybe stress echo, or maybe cardiac MRI. There's significant ischemia on stress. So then you have to use a coronary angiogram and revascularization. And also in initial approach, I just would like to mention something about anticoagulation. We know we are using anticoagulant. It's very, very important to use anticoagulant during the procedure. It's very procedure during the cath lab. You use basically maybe we are using unfractionated heparin, but this to prevent the stent is being hot. And then, but still you can use enoxaparin or bivalirudin. But our practice is to use this anticoagulant, what we call pre-operative or pre and interventional anticoagulation. But according to the very recent guideline, very recent studies, you can use. So there is no very significant reduction in morbidity. Those who have been given pre of anticoagulation like enoxaparin or whatever before the angiogram. Sometimes they are continuing to 24 hours enoxaparin and sometimes unfractionated heparin before the angiogram. So it's not going to improve the outcome, but it increases the bleeding risk. It's very simple. If you look at the pathophysiology of acute condition non-STEMI, the coagulation cascade is not usually activated. So giving this enoxaparin or whatever, this just prevents your coagulation cascade. So when the coagulation cascade is not already activated, it's a questionable. So but it's still in our practice, we are using. But don't use this anticoagulant for long time. Sometimes we are using 10 days. It's not actually they are just wasting our money, because now especially in current situation, so we have to save everything as possible. So don't give these things unnecessary. And just about dual antiplatelet, I think he will talk, but just as one uh, raise a question. Dual antiplatelet test you use all the guideline recommend 1 year. But if there are no bleeding or there is no the risk of ischemic events are higher, you can give further. But if the bleeding risk is high, there are recent trial. If the bleeding is high, you can stop early as possible once single antiplatelet. So when you use single antiplatelet now until now, the aspirin was the cornerstone of this management of antiplatelet. Now aspirin is now gradually going away. Now what they say, if you want to stop antiplatelet, better you stop aspirin early and then continue T2 Y12 inhibitors. Okay, and then again just long-term pharmacovigilance management. So irrespective of invasive or non-invasive, they should be on dual antiplatelet at least for 1 year, and they should be on lipid lowering drugs, statin. Your statin LDL target is 55, and if you cannot achieve 55 with statin, so you have to add the second one, ideally PCSK9 inhibitors, because it's associated with reduction in plaque volume and plaque fracture, not the acetamides. Acetamides also help, but it's better if you have PCSK9 inhibitors, but we don't have much. And then other drugs, AC inhibitors, yes, I think better. You have to continue AC inhibitors or ARBs lifelong, because it has plaque stabilization, it has endothelial stabilization effect. But what the guideline recommend, when the ejection fraction is less than 40, so you have to continue lifelong. But now even the most recent studies suggest that the continuation of AC inhibitors and ARBs have better outcome. What about the beta blockers? Beta blockers indicated as it is non-STEMI, you have to start beta blockers as early as possible. And then if the ejection fraction is below 40, you have to continue lifelong. But when ejection fraction come back to the normal, like when ejection fraction come back to the 60%, after 1 year, actually beta blockers is not going to improve the mortality. Sometimes it increase the mortality. It's depending, especially patient with diabetes. Especially patient with diabetic, right? So when the ejection fraction is come back to the normal, maybe after 1 year, so you have, because it's very simple. If the ejection fraction come back to the normal, no scars or no associated VT related events. So then what we are treating? So we can take it off. Especially patient with diabetic. So beta blockers, be cautious. But when there is heart failure and acute coronary syndrome, you have to use it. But when the ejection fraction come back to the normal, especially in ischemia, so you may have to think of, and also you can switch for another beta blockers, nebivolol and carvedilol. So safe in both diabetes and in all spectrum of non-STEMI. Yeah, I think yes, rehabilitation I'm not going to talk. So I would like to conclude my presentation. If you have any question, I can